my screen. All right. I hope everybody can see this. Put it in the big view here so everyone can have a look. So thanks for having me today. I'll be talking to you about some of the estimates that we've recently published about the future mortality from pathogens of epidemic and pandemic potential with a focus on respiratory pandemics. So I'll start in by saying the way that we do our modeling takes account of many different factors. And so we're not just looking at historical data because we know that while the historical data, especially with the experience of COVID, does offer a lot of rich information, it does not encompass everything that could possibly.
Nita, you've gone on to mute.
Okay, well, good. I didn't get very far. So sorry, let's start over. So I'll just go back a slide. So today I'll be talking to you about the estimated future mortality from pathogens of epidemic and pandemic potential. This is from a working paper that we recently published with the Center for Global Development and the Disease Control Priorities 4 initiative. And so we have estimated risk from respiratory pandemics as well as viral hemorrhagic fevers. But today I'll focus on the respiratory pandemics. So our modeling framework encompasses not just thinking about what we've observed historically, as often is done with many types of, trying to look at risk. We did have the experience of COVID most recently that everybody, is top of everybody's mind, but that really is just one event out of many possible events that could happen. And so we want to use modeling approaches to understand what the potential is for that future risk. We also want to draw from different disciplines, including from very rich work that's done in natural catastrophes, such as for hurricanes and earthquakes, to use extreme events modeling to understand what the tail risk is and to capture what that potential might be, because a lot of time traditional approaches will underestimate that risk. So we've built a disease risk modeling framework that encompasses many aspects of the factors that can drive this risk. So we start with estimates of where wildlife to human spillover may occur, because we know that there is a high potential for these types of events to arise from an animal to human transmission. We then propagate these events. They're seeded into this global spread model where we have an epidemiological compartment model structure that propagates the disease and spreads it from person to person within the global population. And this is modeled at thousands of subnational geographic areas. We then also incorporate mobility networks. So we know that travel patterns can be a leading cause of importation of this disease when it's spreading to many locations. We saw this with COVID. We've seen it with other prior pandemics. So it's important to incorporate that mobility patterns. And we also account for a social science dimension, the levels of preparedness, the potential interventions, the capacity to respond. And so all of these factors are also encompassed into our modeling framework. Now, we can't always include everything. So for this particular study, we've really focused on the estimates of mortality, but we recognize that there's many other potential contributors to morbidity, to economic loss, and those are not included or not covered in this particular study that we did. We wanted to include direct deaths. So a lot of times we have with infectious diseases a lot of underreporting. Not everything will make it to official reporting channels, whether it's people who aren't seeking medical care or laboratory testing is not done or for whatever reason. So a lot of times the statistics that come out actually are an underestimate of what's truly happening. So we wanted to account for that in our modeling. And this we believe would account for the true potential impact. For this particular study, what I'll talk about today, we included pandemic influenza and epidemic and novel coronaviruses. So a potential pandemic caused by the new H5N1 influenza virus would be a type of pandemic that would be covered within this modeling framework. And while we did in the paper talk about filoviruses and Nipah virus under a different section, which feel free to see the paper. I think the link is here, and I think that will be put into the chat as well. For this particular talk, we'll just focus on the respiratory pandemics. And there were many other things we did not cover in this analysis. We didn't cover endemic disease, vector-borne disease, bacterial pathogens, that while we did include pneumonia complications caused by viral pathogens, and some of which are caused by bacterial pathogens, we didn't include only bacterial pathogens. And then several other things. So I think that the takeaway from that is the numbers I will present, we consider those to be a lower bound estimate for the level of risk. So without further ado, I'll talk about our general findings. We found that respiratory pathogens are the dominant driver of pandemic risk. And this is very consistent with previous work that's been published in this domain. And we also found that the expected losses, or the estimated average losses per year, are heavily driven by tail events, or events that are in low frequency but high severity, which is a sobering thought, given that these could be very severe events that occur and could be truly catastrophic. When we compile all the information from our multiple, so how we came up with this is that disease spread modeling framework I explained in the prior slide, we run hundreds of thousands of simulations with different initial conditions. And this is how we end up with our estimates of a full probabilistic distribution of what the potential risk would be. We then average this over all the events of all of the hundreds of thousands of simulations. And what we estimated is that the average annual deaths from pandemic respiratory events is about 2.5 million average annual deaths. And we can also look at this from a probabilistic standpoint to different parts of that epidemic curve, or the probabilistic distribution in the exceedance probability function. And we can see that in any given year, for example, a pandemic causing 10 million deaths has a 4.2% chance of occurring, which I think a lot of people don't appreciate, that there's a chance of a pandemic occurring in any given year. And if we look to how that accumulates over time, if we look at a 25-year time horizon, this ends up being a 66% chance. And so that's more than 50% chance in the very near future, in 25 years. So another sobering thought. And how to think about these average annual losses. So we estimated the 2.5 million. If we put it in a per 10,000 population framework, that's about 3.2 per 10,000. Pandemic influenza is the main driver here. It accounts for about 2/3 of that risk, whereas novel and epidemic coronaviruses is 1/3. And I think this is a really important factor to think about, which is, while this is the average over the entire distribution we have, this isn't, or we shouldn't think about this the same way as events that are occurring on an annual basis. So you might, for example, in this graph, see that this darker set of curves is something that has a recurring frequency on an annual basis, has the same average annual losses as this large spike, which would come from a single large event, a tail event that we would have modeled. And so while both of these different these events have different characters, but have the same average annual loss. And you can see how these types of spikes, these mortality spikes, as they're often called, can be play a very heavy toll on the medical infrastructure, on hospital beds, on personnel, and something we did see in COVID, and I think will have a lot of implications for medical oxygen as well, which we'll hear about soon. We also looked at this on a regional basis and found that the largest risks remain to be in sub-Saharan Africa, and we also looked at this not just as the average annual deaths, but also standardized it for age. Because one thing we saw in COVID, for example, is that the age distribution can be very important to take account of because it can mask the types of differences you might see between countries. And so if you didn't account for it, then you may think that certain countries or certain regions did better than they actually did, given the age distribution of deaths. So that's something that we've looked at. So we saw sub-Saharan Africa still in a kind of the worst position here with the highest amount of standardized average annual deaths, followed by Central Asia, and then India. So again, these are numbers based on our modeled estimates, and some may point out that for example, the estimates that have come out from Africa in some cases, appear to be at, not as bad as what these numbers would say. However, we would point out that other types of studies looking at excess mortality and seroprevalence estimates that try to take account of the underreporting that may be present and the differences in age distribution do actually find that that there were higher levels of mortality in places like sub-Saharan Africa. So I'll kind of bring it to a closing, talking about what we think from our estimates about the potential for another COVID level event, an event as severe as what we saw in COVID-19. So the likelihood of an event of that magnitude based on mortality, we have estimated in any given year would be a 2 to 3% chance. Over the next 5 years, a 10 to 14% chance, and over the next 10 years, an 18 to 26% chance. And if we look over the next 25 years, we see about a 50% chance of an event of that magnitude. And the other factor, you may recall earlier, I said that we believe our estimates are a lower bound estimate because there's a lot of things in there that that could increase risk that we have not accounted for. So this may actually be an underestimate. I think this is a number that a lot of people find higher than generally believed, and so we're trying to make sure to get the word out that the respiratory pandemic risk continues to be high despite the one that we just went through. And these events are not a once in a century occurrence, but rather can occur much more frequently. We can't ignore the tail risk, those large events that may be less frequent, but can be very severe and could be more severe than what we've historically observed. We have events that we've modeled that dwarf a COVID level event. So some events, with hundreds of millions of deaths worldwide, which is a frightening thought. But I don't want to leave everybody with this with a pessimistic view on this, because we have within our power to substantially reduce this risk. And I'm excited to hear from the next speakers who hopefully will tell us more about how we can reduce this risk from the standpoint of providing medical oxygen, but also reducing the likelihood of the spillovers occurring, being able to detect and respond more quickly and more effectively to these events. So with that, maybe I will stop there and I'll stop sharing. And thank you everybody for your time.
Terrific, Nita. Thank you so much. And everything shared on this call, we're going to be sharing with you after this call and an email tomorrow. So don't worry, you'll get all these slides. Let's move now because we want to make sure all our speakers have their 10 minutes. So now Ramanan Lakshminarayan, I cannot list all of Ramanan's accomplishments, just to say he leads One Health Trust. He's deeply involved in the pandemic effort. He was front lines on the India crisis when it hit. So he has a lot of expertise to share. And we really want him to shed some light on his view on the current state of preparedness and what we need to do to be prepared. Ramanan.
Thanks, Lee, and thanks, Nita, for that very strong introduction. Obviously, quite concerning the numbers that you're projecting. I was going to show slides on, and then I realized it sort of boils it down into just the disease itself, whereas it's almost like the experience of COVID in India and tackling the problem of oxygen was so much more than just numbers. Just a broad brush outline of what COVID in India was like. COVID in India was primarily two waves, a first wave which was smaller in 2020, and then a rather sharp peaked one in uh, March and April of 2021, when most of the deaths occurred. There's a lot of really uh, lot of data and papers, many from our group, on case fatality rates, who was affected, what was the reason behind people, dying during both of the waves, what the excess mortality was. So this is all very well documented. What is less documented is what happened with oxygen during COVID in India, which I think was much more of an experience that one had to go through there, because there isn't much by way of writing on specifically this. But first of all, India went into a lockdown on March 24th of 2020, as many countries did. And it was meant to be a period of time to prepare for the pandemic to essentially hit India at full force, given that it has a large or it had a large naive, immunologically naive population. Many things were prepared for, but unfortunately, oxygen was not one of them, despite the fact that it was very clear it was a respiratory pandemic, and that simple things like nasal cannulas and masks, and breathing apparatus, and of course oxygen cylinders would be essential. There was really no thinking around this at all. Meanwhile, there were treatment guidelines that were widely used, and a lot of it was not really based on science. Hydrochloroquine, which was very clear was not going to work, was on the treatment guidelines all the way through to September 2021. There was ivermectin was very much on the treatment guidelines. There were some monoclonal antibodies for which there was no evidence. There was obviously plasma therapy, which worked with fairly limited effect only in some cases. But overall, the early administration of corticosteroids, which there was evidence that they did help in sort of calming the cytokine storms, but not if given too early, ended up doing a huge amount of damage in India. And as a personal story, the way I got involved was our chief financial officer, who was a 41-year-old with a 5-year-old child and his wife. He had been very careful to not get COVID because he was afraid of transmitting it to his elderly parents. As luck would have it, they got infected first, and then they transmitted it to him. And he was given a long list of medicines, which include all the ones that I mentioned, also included azithromycin, Dolo, which is, I think, another paracetamol, which they use, whole bunch of drugs, all of which are needed because he was essentially without symptoms. But those medicines were really what put him into a situation where he his body was not fighting back because he was early on steroids, and he ended up with a fairly bad case of lung scarring and was on a ventilator fairly soon, in just a week or 10 days. And meanwhile, they kept increasing his medicines. And this was the period when India went through some significant oxygen shortages. And what would happen was that every day, every night, we'd have to send the team out, often to drive 5, 6, 8 hours to try to get oxygen for him. And they would go, about a few hundred kilometers away from Delhi to see wherever it is that they could get oxygen, all for him. And it was obviously heartbreaking because we could probably go get 1 cylinder of oxygen for him. And obviously none of the other patients had oxygen in that place. So we organized a campaign called Oxygen for India, essentially around bringing in supplies for oxygen, which at its peak was delivering 3,000 concentrators and 20,000 oxygen cylinders with oxygen in various parts. At its peak, it was in about 16 cities across India. But it really brought home this clarity that oxygen was actually available. There was medical oxygen available in some places, particularly where there were industrial factories where oxygen was produced. It just wasn't in the places that it really needed to be. And the transportation apparatus to bring it was simply not available. And in short notice, you couldn't really make oxygen in any way. And so this was a combination of obviously it was a personal need, and unfortunately we lost our CFO about 3 weeks in, and not only did we lose him, we lost his brother as well, who was in the same situation, and it was heartbreaking because these were deaths that just did not have to occur at all. Neither of them should have died of COVID, and either the poor medication could have been avoided, or of course they could have had oxygen. But as luck would have it, they didn't have either of these, and their parents lost both their sons within a space of just a month. And it was just absolutely devastating for everyone. But I think what we really have been trying to do since that is work on a concept of oxygen, of a national oxygen grid, not so much like a physical grid, but an information technology platform which can essentially bridge the gap between supply and demand and indicate whether there are supply-demand gaps. So what we have is a fairly simple yet sophisticated piece of software that is now being used in a few states across India. And it essentially allows one to track both the supply of oxygen, but also look at demand for oxygen. And you could observe where there are short peaks, and that would allow suppliers to make sure that the demand is actually met in those places. So I think that these are the kinds of tools that would ensure that even during normal times, we never have oxygen shortages again. But these are all supply side interventions, and the demand side interventions are also equally important. The reason why a lot of people died because of lack of oxygen was because many providers, particularly if they were not in the cities, were not familiar with the use of medical oxygen. And unless we are able to develop strong guidelines, train people who are non-physicians, respiratory physicians in the use of oxygen, we could face the same crisis again, even if oxygen were to be available. So it's one thing to have the oxygen and another thing to have the knowledge base amongst the healthcare workers to be able to use it. And to that end, we've developed a fairly extensive set of guidelines on the use of medical oxygen outside of hospitals. And this is something which we hope will be helpful both in India and other LMICs. So I will stop there and hand over to the next speaker. But I think we're all back for questions and happy to take any questions at that time. Thank you. And thanks, Leith, for organizing this.
No, thanks so much, Ramana. Thanks for sharing that personal story. We always have to be reminded about the real stories behind the pandemic. So now, great pleasure to introduce Priya Basu. We introduced her at the head of the hour, but just for those who joined later, she leads the Pandemic Fund Secretariat at the World Bank. The Pandemic Fund is a vital tool to help countries prepare. So Priya is going to tell us where they're at with the fund. And there's a very, very important round of funding proposals open now. So listen very carefully to what Priya is about to tell us.
Thank you so much, Leith, and it's a pleasure to join you today. I have a few slides, so we can just move to the next one, please. So just as a background for those of you who don't know about the Pandemic Fund, we were established on the heels of COVID-19 in recognition of the fact that despite several previous pandemics, the world had chronically underinvested in pandemic prevention, preparedness, and response. And the need for stepping up these investments urgently is underscored by factors like climate change that are exacerbating the risk of pandemics. Experts predict that there's more than a 50% chance that another COVID-like respiratory pandemic will hit us within the next 20 to 25 years. And so the pandemic fund was put together very quickly in 2022 as an innovative addition to the International Health Financing Toolkit. It's a first of its kind multilateral platform that's dedicated to making investments in pandemic prevention, preparedness, and response during what we call peacetime, recognizing that the next battle will come again very soon. And the goal really is to then, in the face of that future health threat, to ensure that all low and middle income countries have the ability to quickly detect and contain these pandemics, laboratories that can, quickly scale up testing, a health workforce that can be rapidly deployed to all parts of the country where that new pathogen has emerged, and surge capacity that can be called upon. So that's really what the pandemic fund is about. And this slide just shows you how quickly we were established. We were only asked to set this up in April 2022, and then by September we were already up and running. In November of 2022, we were formally launched at the G20. And as of today, we've already managed to mobilize more than $2 billion in seed capital. We've awarded our first round of funding that was awarded in July of 2023. And then we announced our second call for proposals last December, and it's currently open. It's a 500 million call that closes on May 17th, and I'll give you more details on that later. But next slide, please. This just summarizes the objectives and value addition of the pandemic fund. So as I mentioned, it's the first multilateral financing mechanism that's dedicated to pandemic PPR, if I can use an acronym, it supports and reinforces capacity building and implementation of pandemic prevention, preparedness, and response under the International Health Regulations 2005 and other internationally endorsed legal frameworks that are consistent with a One Health approach. Some of its value additions are that it's able to mobilize funding from non-ODA sources, that is, private philanthropies, in addition to governments. It complements domestic efforts and investments in pandemic PPR, and as well as financing provided by international institutions to help bring programs to scale. It serves as a platform of advocacy, and it promotes coordination and collaboration among national and international agencies that are engaged in pandemic PPR, serving as an integrator to defragment the landscape, bringing coherence to funding streams around country and regional needs. So we take a systems approach, recognizing that strengthening pandemic PPR really requires all of government, all of society approaches. And we are designed with the necessary flexibility to work with a range of existing institutions to fill their financing gaps, and importantly also to incentivize countries themselves to do more in this agenda. Next slide, please. So as I mentioned, we went forward quickly with our first call for proposals, and the funds were awarded in July of 2023. This was a pilot call, so it was small. The envelope initially was $350, and ultimately $338 million worth of funding was awarded to 19 grants, which covered a total of 37 countries. These 19 grants, or 19 grants for 19 projects, 16 of which were single country and 3 of which were multi-country, included a strong focus on One Health for prevention at source, as well as on antimicrobial resistance surveillance and community engagements and CSO participation in both project design and implementation. And every dollar of grant funding that we awarded leveraged $6 in international and domestic financing. So, that is the catalytic impact that we were able to achieve. And 75% of the grants awarded were to low income and low-income and low-middle-income countries. Next slide, please. So what are some of the key takeaways from the first call for proposals? First of all, we saw a tremendous demand for our grant funding. There were 135 eligible applications received from 132 countries, and the total ask was 2.2 billion, even though it was announced that the envelope was only 350 million. The largest number of requests we received were from Sub-Saharan Africa. There was a strong interest in all three thematic priorities, which was surveillance, labs, and health workforce. And there was a recognition in the proposals that we received of the need for multi-sectoral all-of-government approaches to pandemic PPR. So, One Health approaches that brought together ministries of health, agriculture, environment, animal husbandry, and of course, finance. And all the successful projects, the 19 projects that were selected, involved multiple sectors. Next slide, please. So turning to the second call for proposals that was announced in December of 2023, this has a $500 million envelope. And again, it prioritizes investments under those priority areas of early warning and disease surveillance systems, both human and animal, laboratory systems, again, human and animal, and many of the projects actually connect human labs with animal labs, and human resources, public health, and community workforce capacity. And these areas were selected based on extensive stakeholder consultations and factoring in that several global health actors like the Global Fund, Gavi, the World Bank, CEPI, etc., are working also to step up their investments to help address preparedness for infectious diseases through broader health system strengthening, including medical countermeasure stockpiles, including vaccines and so on. So, based on stakeholder consultation, these three areas were identified, three discrete areas where the pandemic fund was felt where it was felt that the pandemic fund can fill the most critical funding gaps in the short term. Next slide, please. This is just an overview of the timeline and process of the second call for proposals. So we're now at a stage where we're coming close to the deadline for submission of proposals on our portal. That's May 17th of 2024. After that, the Secretariat will undertake a screening of proposals for eligibility, and then it will pass on all eligible proposals to the Technical Advisory Panel, which is chaired by the WHO and co-chaired by or vice-chaired by the Executive Director of the Caribbean Public Health Agency. And then the TAP will review all these proposals based on a methodology and screening criteria that have also been posted on our website. And we can post a link to that in the chat. And then the TAP will give its recommendations, and then ultimately the board will meet around October to make the final allocation decisions. Next slide, please. And this is all the information to apply, and these slides can be shared with you later so that you're able to access quickly if you haven't already our website and the electronic application portal that's on the Pandemic Fund website. Next slide, please. So what do future rounds of funding look like? What does the future hold for us? We're currently in the process of developing our strategic plan, which is due to be adopted by the governing board later in May. The strategic plan was prepared with wide consultation from stakeholders. Over 400 stakeholders were consulted, and then the plan was put up on our website for comments from the public. Which for a 2-week period, which closed on Monday this week, that is yesterday, I believe. And there were different approaches to funding that were outlined in that strategic plan. Right now, we're in the process of updating it based on the comments that we've received through the public consultation process. But the approaches include the possibility of moving away from an open call for proposals to rolling deadlines, calls that have kind of rolling deadlines rather than one-off calls. There are also ideas there to do more targeted rounds of funding for specific needs. This strategic plan is over a 5-year period, so it puts forward what the pandemic fund can do differently. It also learns from the experience. It draws on the lessons that we've learned from our experience from the first round of funding. It looks at options on how to address high demand with limited resources and ways to make it more likely that strong proposals will be funded. And the strategic plan will begin operationalization in the 3rd and 4th quarters of 2024. Next slide, please.
Priya, just 1 minute left.
Sorry. So I think this is the last slide. So this is really just about the different kind of approaches, the possible allocation modalities that might be available in the future over the 5-year strategic plan period. I do want to note, though, in my last 50 seconds that our medium-term strategy recognizes the evolving global health financing ecosystem and the pandemic agreement negotiations that are ongoing right now. And in case you haven't seen this, on April 5th, I believe, the Pandemic Fund Board issued a statement on the links between the Pandemic Fund and the Pandemic Agreement, saying that the Pandemic Fund stands ready to play a strong role in supporting the implementation of the Pandemic Agreement and the core capacities of the IHR. And the statement also said that it stands ready to explore accountability mechanisms with the eventual governing body or bodies of those instruments once decided. So this really recognizes that the Pandemic Fund's mandate is closely aligned with the core capacities of IHR and potential activities that countries would need to implement under any new agreement or accord. And that we're already demonstrating our capacity to coordinate between international, regional, and global agencies and attract additional investments for PPR, and that we're well positioned to support countries on their PPR financing needs and gaps, well positioned to inform resource allocation decision making and support countries in accessing various funding mechanisms, bringing coherence to funding streams. So we're looking forward to the conclusion of that of the negotiations around that accord, and to helping with its implementation. Thank you, and back to you.
Thanks so much, Priya. There's a couple of questions in the chat for you and your team from Lucas Hill and Karen Turner. If you can answer those in the chat, would be terrific. If I could just let everyone know, the Pandemic Fund materials are exemplary. Every question you asked, they've answered in some document somewhere on the new website. So please spend the time going in and reading the guidance note and the materials on the website, and what Priya and her team can answer here, they will. Let's move now to Nina, and then we'll have some time at the end. We have some partner interventions from members of our coalition. But Nina Schwalbe, live from Geneva. What is happening with this pandemic agreement, treaty, accord? Is it going to work? What's your unfiltered take? And if you're not following Nina's commentary on X, I'm going to drop her X link into the chat. You must. This is the place you need to go to get the latest advice on what's really happening. Nina, over to you.
Great. And I'm sharing my screen. Thanks so much. Can you see it now with the deck that says pandemic agreement? Great. Well, thank you so much. And big thanks to Laith and her coalition. Like Ramanan, we also had a personal experience with lack of oxygen, and rest assured it wasn't just in low and middle income countries, also in high income countries and in the richest cities in the world. There was a huge oxygen crisis resulting at the beginning of the COVID pandemic. So let me move to the agreement. For those of you that don't follow this on a day-to-day, time frame. There are basically three instruments that were hopeful potential mechanisms for change following the pandemic. One was a high-level meeting, which was supposed to mobilize high-level political commitment. One was an update to the international health regulations, which is sort of the day-to-day of what countries are supposed to do to be able to declare a pandemic emergency of international concern, and then the follow-on actions, and then a new treaty, which was supposed to be bigger, better, and bring together more than health, high-level political commitment to change how states interact with one another. I'm going to dive a little bit more into the pandemic agreement part of it. This is a same slide, same topic, different slide, but about high-level declaration, which was about driving political will, IHR, which is about preventing and control of the spread of disease under one particular part of the WHO Constitution, also legally binding, and this theoretically new treaty. And it's called treaty, it's called accord, it's called agreement, all the same. The idea is, again, that it's a legally binding agreement between member states who agree to it to improve their collaboration during, before, during, and after a pandemic. So the pandemic agreement process began in November. It was supposed to be, there are a couple of different articles under the Constitution of the World Health Assembly, which enable legally binding global work. This one was chosen because it's slightly broader than the one under which the international health regulations were negotiated. And as I said, it was supposed to be whole of government, whole of society, and encompass a lot of the things that were deal breakers in terms of equity for the COVID-19 pandemic. Equity, established principles and targets, talk about how to share data and data samples more fairly. I think very often the kind of classic example of super unfair was when South Africa identified the Omicron variant, sent the genetic samples in so that companies, particularly in the West and others, could make countermeasures, and then suddenly had their travel shut down, which is not supposed to happen under IHR. Priya and others talked about One Health and this idea that planet, animal, and environment are people are connected, and that's been underplayed, I would say, in our thinking about pandemics, and also that you need political commitment in order to get stuff done. The process has been either a short or a long one, depending on how you view the world. I say sometimes a long one because after the Chernobyl accident, I think it was in 1986, it took less than 6 months to put together a binding treaty on nuclear safety. That was very quick. This has been in process for a full 2 years with many drafts called zero drafts, drafting groups. It's being negotiated in Geneva by something called the Intergovernmental Negotiating Body. And it has had a series of drafts which were sort of pre-drafts. Only recently there was a real draft negotiating text that was released in March of just this year, which I think was even just last month. And member states of the UN through the WHO and at the WHO have started to get into the details of what this looks like. That's where we are this week. We're at the final week of negotiation, this week and next, before a resolution is supposed to go to the World Health Assembly, which proposes and recommends adoption of an accord. This is just an idea of, just for those of you who aren't in the day-to-day, of what it looks like. It has 3 chapters. One is preambular, the other is sort of the meat, and the third is really about the governance and reporting. And if you look on the right side of the slide, you see the type of topics that are being discussed: One Health, surveillance, resilience, research and development. So where are we right now? Well, unfortunately, not as far as we would like to be. There are and continue to be a number of sticky issues. I mentioned the South Africa issue about sharing genetic and genomic material and what are the benefits. So if I'm a low-income country and I share information on a respiratory virus, will I actually benefit from from the countermeasures. For example, if high-income countries develop vaccines, will I benefit for that? There are sticky issues around R&D conditionalities. A number of non-governmental organizations and others are saying that when public funding goes into development of a countermeasure like a vaccine, that countermeasure should be available to everyone, and that the intellectual property associated with it should also be available to everyone because it's public funding. Financing is a very tricky issue. Low-income countries in particular don't want to commit to things that they know that they can't implement. For example, widespread surveillance around One Health without an associated commitment of money to be able to support that. There's also some trickiness about the role of the pandemic fund, who governs financing, et cetera. Intellectual property, this is always a tricky issue. There was felt that at the World Trade Organization, not enough progress was made in terms of waivers that could have been applied during the COVID-19 pandemic. Setting aside products, when should high-income countries set aside a certain number of products? And then also governance. How is this governed? Is it governed by ministers of health? Is it governed by higher level heads of state? Is it governed through regular WHO processes? Is it governed outside? These are all tricky issues, and they have been tricky issues for the last year and a half, and they're still tricky issues. The problem today is that we have about 8 days left to negotiate this treaty, or not we, the member states. And I say not we, the member states, because there's been a real lack of transparency and inclusion of civil society or non-state actors in this process. It's happened behind closed doors. There's been very little information shared. So they have really the next 3 days, because what they've promised the world is that they're going to tell us on Friday whether or not they think they've gotten far enough to be able to propose something to the World Health Assembly. There are a number of different blocks. Countries are basically working together in blocks. There's a group for equity, which is pretty, it's mostly low and middle income countries, really focused on things like TRIPS waivers and pathogen access and benefit sharing, and saying we need access to countermeasures when and if they're developed in the same and real time as high income countries. The Africa group is negotiating as a bloc. There's the anti-sanction group, which is Russia, Iran, and others, who say sanctions shouldn't apply during pandemics. Everybody needs access to countermeasures. There's high-income countries, EU, US, Canada, Japan. Most of those civil society feel being heavily driven by pharmaceutical companies and pharmaceutical lobbies in those countries. And then also this idea of manufacturing countries, which is that some countries that are also low or middle income countries, like Bangladesh or Brazil, also have large manufacturing industries. So they, in some areas, behave outside of these other groups. In terms of governance, it's very weak. In the most recent draft, there really is none. We, as a think tank, Spark Street is a think tank, and we publish a lot on governance. And we think, a lot of public health people on this call, what doesn't get measured doesn't get done. There's no accountability written into the current draft of the treaty. They'll sort of take stock when they want to. There may or may not be compliance with the treaty, but there's nothing written in stone yet in the treaty that is either about stock taking, accountability, reporting, you name it, it's not there. So that's where we are today. Next steps, as I mentioned, is right now we're in the thick of it, or member states are in the thick of it, locked in rooms at the WHO. Friday, there's supposed to be a stock taking. We're hoping that will be a public event, but we're not sure. And stock taking on whether or not they're going to make it, with the idea that substantive negotiations would end on the 5th, and then they could tinker around with any remaining language to be able to present this to the World Health Assembly on the 1st. Spoken very fast. I hope not too fast. I wanted to leave some time for questions. And as Liz said, we follow this pretty closely, and you can follow us on Twitter for sort of real-time updates. I'm afraid we're getting to the end of the road, and it's not looking so good right now. Thanks. Thanks for the chance to speak to you.
Thanks, Nina. And I put your link in the chat as well. So please, everyone, just go follow Nina now. It's the clearest, most honest advice you'll get on what's going on with the negotiations. So thank you. Okay, we are a coalition. of more than 100 members, and we have some interventions as we usually do on our call. So we have 3 partner interventions related to what you just heard. A number of you are confused about the Pandemic Fund. Is the work that we do in our coalition, which is all about medical oxygen, pulse oximetry, access to respiratory, is it in scope for this second round? PATH have stepped up to provide some guidance. So I'm going to call, I think it's Carrie who's with us. They've produced a note, a sort of an advice note. Carrie, did you want to introduce that and put the link in the chat?
Sure, thanks, Leith. As some of you may know, last year, kind of when the Global Fund expanded the inclusion of medical oxygen and respiratory care systems in their funding opportunities, PATH created a 2-page fact sheet kind of incorporating where oxygen could be included in those efforts. This go around, we've done a similar exercise for the Pandemic Fund. We really looked at all the great guidance documents that the Pandemic Fund has created and kind of looking at where countries are seeking to incorporate pulse oximetry and medical oxygen into their grant proposals for the Pandemic Fund. And we've created a similar 2-page fact sheet that kind of gives an overview of the Pandemic Fund in terms of like key considerations, who it's applicable for, the types of proposals and grants that are open, key kind of actions where partners can step in and help countries to develop their proposals and properly incorporate medical oxygen and respiratory care, and then critically where medical oxygen and pulse oximetry fits into the critical priority areas of the Pandemic Fund. So we have a nice two-pager with that information, and I'll pop that in the chat and hope that it can be a really critical resource for those who are trying to ensure respiratory care is incorporated into their PPPR efforts.
Thank you, Carrie. So watch out for this link, and Lucas and others who've asked questions, who are already working with countries now with ministries of health, take a look at this guidance note. I can say we as a coalition are working with the Ugandan Ministry of Health, Malawi, Senegal and Nigeria on a multi-country proposal for regional centres of biomedical engineering excellence related to category 3 health workforce, pandemic health workforce of the second round. And we encourage all of you to talk with your ministries of health about their national application to the Pandemic Fund. But remember, there's also the category of multi-country. So this path note will help you get a handle on whether you feel you have work that's in scope. Here's a little taste of work that might be in scope. Have you ever thought of pulse oximeters as tools of respiratory pandemic surveillance? Eric McCollum is working on exactly that. Eric, you want to give us a quick voiceover of some of the new work you're doing with pulse oximetry?
Thanks, Leith. Hi, everybody. So what we've been working on is a pulse oximeter device called Pafomla, which is a mobile phone pulse oximeter that uses reflectance technology. Been co-developed in South Africa and the United States with South African healthcare workers and pulse oximeter engineers in the US. It's passed human accuracy and biomedical regulatory criteria, so it's eligible for CE marking and FDA clearance. And the 2 unique features of this device are that it doesn't need a probe like many pulse oximeters do. This really unlocks the device to be used across the lifespan, especially in the youngest infants and children who are at the greatest vulnerability to low oxygen levels due to novel respiratory viruses. And then secondly, what's unique and relevant here is that the data that it produces for blood oxygen levels is interoperable with surveillance dashboard interfaces like DHIS2. And so while this is in its beta phases, this use case would allow there to be risk-based surveillance to supplement kind of pathogen-based surveillance. And so that is kind of what can be envisioned. So thanks, Leith, for the opportunity.
Terrific, Eric. Thank you. And we're going to give you a picture of that device in the newsletter tomorrow. And the third and final, Salam, to your question, what's happening in the next months or 2 about medical oxygen and pandemics? So the WHO is hosting the first ever national oxygen scale-up framework meeting for member states in Dakar, Senegal, from the 14th to the 16th of May. So very soon. They've just launched their event page on the WHO website. I've just put the link in the chat. You'll be able to, if you can't attend this, and it is primarily for Ministries of Health, you'll be able to watch it. There'll be a link that will be shared where we can watch that. And indeed, pandemic prevention, and preparedness and response for medical oxygen and pulse oximetry will be part of this event. There are also several events at the World Health Assembly this year organized by the New Global Oxygen Alliance, or GOAL. So we'll summarize those tomorrow in the partner actions email. We always send out an email following these calls with 10 actions that we encourage you to take. And indeed, our speakers today, our 4 speakers and our partner interventions have given us a lot of actions we can send you off on your way. But our main purpose today was to really shake people up about the risk, the high risk of another respiratory pandemic in our lifetimes. At least if you're under 60, we're likely to see one of these again, and we're not prepared for it. But the good news is we learn a lot from COVID, and we do have a lot of new ideas, new initiatives, new devices that are coming to market. What's really important is that our tools like the Pandemic Fund, the Pandemic Agreement, fully embrace this risk of respiratory and build it into the work that they're doing. We haven't seen that yet. We've seen a focus in other areas. So if it's one call, I think, that we have to the global health community and to Ministries of Health, it's don't forget the risk of respiratory pandemics, and don't forget it can't all be up to a vaccine. When we hit another one, we need diagnostic and treatment capacity. We just can't rely on development of a vaccine. And as COVID taught us, even if we get a vaccine, it takes so long to get to the places it needs to be. People die for lack of access to oxygen and other respiratory therapies. So I want to thank our 4 speakers today. It was truly a stellar group. Encourage you to look at the video when we share it, review the slides when we share them, and get much more active in this area of respiratory pandemic prevention, preparedness, and response. This is the first of 3 calls we'll do on high stakes conversations. The next one's on oxygen and the Sustainable Development Goals. So stay tuned for that. But thanks everyone for dialing in. We wish you a very safe and productive week. Consider me shaken, says Jim and Sarah. Thank you, Jim.
Awesome session. Congratulations, Liz and team.
Thank you, Rosanna. Lovely to hear your voice.
Bye.
Bye-bye. Thanks for being here, Joe. Brittany, Immaculata.
Yeah, thank you, everyone.
Thank you, Peter. Thanks, Alpha, Kalechi. Thank you, Themba. All right, I'm going to close out the call now. Thanks everyone for joining.